of her Vivitrol. It's just not, it will be to her detriment. So why I presented this case is that I just needed you all feedback, because I feel like I'm not doing the right thing. I feel like, well, everyone else has to go back to IOP and have an escalated level of care. I can't. I want her to come. I've offered her to even meet with me one-on-one, just so we can go ahead and get her some skills training in, but she doesn't show up, right? And so I feel really bad as a physician, because I feel like I have a double standard. I'm allowing this lady to come to our program. I'm still giving her her Vivitrol, and she is still using THC. So we had to ask her to go ahead and get her medical card, because she feels THC is very helpful for her seizure disorder. She had been seeing a neurologist for quite some time, and actually, since she stopped using heroin, she stopped having seizures. However, she thinks she has, she says she's been diagnosed with non-epileptic seizures, and she thought that initially they were epileptic, but her neurologist for several years they keep doing EEGs, and they realize, no, you probably have non-epileptic. So when you sit down and think about it, right? Non-epileptic seizures are linked to stress, psychiatric issues. And for a lot of people, they do cope with THC. So y'all fix me. Tell me how I can help this lady in the spirit of what we do. I know I cannot take away her Vivitrol, but what can I do? Because other people in group settings, seeing her come just once a month, and they know she's still using, it's a problem. Now, other group members haven't told me it's a problem. They're still coming, and they never bring it up. But, and back channel, all of our patients talk and know each other. So that is why I need y'all help.
Dina, can you clarify something? The whole heroin on urine drug screens, were they confirming that? Because heroin only stays in your system for such a short period of time.
I know, it was amazing. Yes, they confirmed it when she was there, and they were shocked too. I was actually thinking, is this a case report?
Yeah, was it diacetylmorphine, or was it morphine, or what did it show in the screens the whole time?
Okay, well, that's back in Rhode Island, so we didn't have it, but they confirmed that it was heroin, fentanyl. So, and that's the first time, that's the first time I've ever heard of fentanyl staying in someone's system for like more than 3-4 days, right?
There's case reports of one in rehabs where fentanyl stays in the system for 2 weeks and norfentanyl for 3 weeks. Yes. So that is definitely a thing.
And we've seen that here too in our outpatients. Yeah.
Why does that happen?
Because it's so lipophilic. It's not. So there's a whole thing on like BMI. I don't know if this lady's a little bigger or not.
She's tiny.
But she's tiny. Interesting. But it's very lipophilic, and the idea is it slowly leaches out. It's probably one of the problems why we have issues in inducting people on the bupe initially, because there's still fentanyl floating around for a while. Even when you think you've kind of overcome it. I was talking with a fellow earlier today about this. If you were to like take your foot off the gas with bupe, even for a couple of days, theoretically the fentanyl will sort of like come back in and start screwing with the receptors again. So that's not shocking with the fentanyl that it's stuck around that long. I think it'd actually be interesting to do like a full blown report where if anybody wants a little research project, if you have a rehab and you have all people with fentanyl, do initial levels when people come in, and then just keep screening them throughout and monitor the levels, because it's something that we're dealing with a lot, and law enforcement doesn't understand. And it's causing a lot of issues with like CPS cases where somebody has an exposure and then 2 weeks later they still have fentanyl in their system. So I can see that being an issue for Slade though.
Right. We do send off confirmations on ours, and we always monitor those levels as well, because they do stay in for quite a while. And I think it depends on what their source of fentanyl is, what kind they're taking in.
Yeah, and it's also probably how much they're using, how often. Somebody who's a very heavy user who's been using for months or years, probably it takes longer. And then you're right, that's a really good point, because the fentanyl that they're getting, I don't know, I'm going to go to Dr. Husted on this, but I'm Jeremy. Maybe there's something different in the manufactured fentanyl. It's not the exact same compound. I know that one of the metabolites is different. You can tell if it's pharmacy grade fentanyl versus Mexico fentanyl, there's different,
Yeah.
it's a different compound, right? One of the metabolites.
I mean, it's weird because I see a bunch. I'm involved in a couple CPS cases, and these send off screens usually have all the weird metabolites for fentanyl, but at the real low amounts, typically you will still only see fentanyl and norfentanyl. I don't see all these like, what is it, like acetyl fentanyl and some of these other ones.
Diacetyl is apparently the one that, or something like that.
Yeah, I haven't seen that on like the low doses. I assume when people are using higher doses of fentanyl, you'll get more of those other like weird metabolites or contaminants in it. But if it's mainly what you see is just very low levels of fentanyl, norfentanyl. I'm talking like 1 nanogram, and usually you'll see more norfentanyl, like 3 nanograms. But
we've only seen it when we've done testing for other things, broader panels, like with 180 things. Otherwise, our panels, the WV only showed norfentanyl and fentanyl.
Yeah, I mean, I see outside of the bigger panels because we don't normally do those either. But when you see the law enforcement, I think the laboratory companies have sold them on these huge panels that they just do for everyone. I have no idea how much they're charging the state to do all these panels, but it's probably incredible. But it still seems like it's mainly nor and regular fentanyl. I don't see a lot of the weird ones. So.
Adina, do you know if this person's doing any kind of therapy?
So no, she is not, because she used to with our therapist. We no longer have a therapist, and so I've offered to do therapy with her. She says, Dr. Bo, I'm kind of busy.
Well, that's a bummer.
Yeah.
Do you know like what kind of marijuana or THC that she's doing or how she's using it?
Well, I know she's smoking it, but when you say what kind, you mean it's Delta 9.
Okay.
Yeah, and she has the gummies, and she also has the vape. Very committed to use for it.
Any change in like that?
Nope.
Okay.
And she's very honest. She told me, I am not going to change this.
Adina, what does she see as the downsides of marijuana, if any? Or
financial.
Okay.
Yeah. So because she supports her household through her disability check. So when her and there have been times when she's not being able to afford as much as she wants, and then she says, I probably should get off this stuff, but I can't.
But it's not habit forming.
No, but she knows it's habit forming. Like, I think everyone in our group agrees with that.
Some of the things you brought up in the history, like the history of schizophrenia, may be related to marijuana use or exacerbated by marijuana use. And I wonder what her goals are, like what is she hoping for in her life, and how does marijuana figure into that? So kind of the motivational interviewing approach to this,
So all of her psychiatric symptoms actually resolved, and she got off of Risperdal when she stopped using heroin. So
sorry. I'm assuming she wasn't using THC when she was in the rehab. So did she see any benefits while she was in that program from discontinuing THC?
No, ma'am. She couldn't wait to restart.
Doctor, did you diagnose her with a cannabis use disorder? Because her opiate use disorder is well treated, and you're treating two different diseases. So I would be happy that you got the opiate use disorder well controlled. I think it's a good thing. I would not discharge her at all.
I mean,
I like it so much. There's just no way.
Yeah, I don't think you're doing anything wrong with her. I mean, at the end of the day, all right, if we're going harm reduction side, would we rather her be doing heroin / fentanyl or smoking pot? I know my choice, but that doesn't mean she should be in the group. If it was me and I had somebody like this, I would probably just see her individually, one-on-one, once a month, and just pull her out of the group, not discharge her, keep her on the medicine, maybe offer some of the stuff, but I wouldn't have her in like the code program. I would still see her. Yeah, that's the way I would go about it for sure, and that's what we've done for people. But I would keep her on. I mean, in considering with now Checkstone's this kind of cure-all for all things, it's probably helping keep her cannabis use maybe under a little better control than you give it credit for too. So it could be doing a little bit where maybe if you take her off naltrexone, she ends up using even more, because there's evidence from meth. I don't think it's ever been specifically studied for cannabis. If it is, I don't know about it, but I wouldn't be shocked if it's helping her avoid it a little bit too. So I would absolutely keep her on it.
Yeah, the average human walking speed is 3 miles per hour, so you can't expect her to do 12. So little steps at a time. You worked on the opioid use disorder. That looks like it's working beautifully. Now move on to this. And yeah, I would, like everybody else saying, go individually with their treatment, because it is going to start to impact the rest of the members in the group. And it doesn't sound like she's using any kind of risky way, but depending on where she's getting this stuff out, could still be some sort of risk. Has there been is like the financial part of it, her hesitation towards getting the card?
Right. She says the card costs $250 and she cannot afford that.
Yeah, it's expensive. But for what you're getting, it would probably be the safest.
Hey, Derek, when I do meet with an individual, and also our other therapists, what do you all suggest I focus on? Because in my mind, I should help her deal with stress and coping skills around grief and family conflict, because those are her driving forces to use. But what do you all think?
Well, grief is weird. That's more just, there's no like, go do this exercise and you're going to be over the grief thing. She's going to have to process it. And that's a lot of just talking back and forth, talking about the loved one that she lost. If she's already saying that there's any kind of internal motivation to stop using it, that is awesome. That's not saying, hey, you're going to be able to get her to stop doing it today, but you can start working motivation on that thing to get her from, okay, I see that there might be a problem, but I'm not ready to, okay, I'm ready. You can start making that. If there's already internal, great. Because usually when they're like pre-contemplation, you got to focus on external because they don't have no internal. So there's a little seed there. You can start growing that. But it might be slow, especially if she's dealing with any kind of compound grief.
I think that grief can be something useful for this patient. I often tell patients, maybe you can honor that person's memory by living a good life yourself. And I wonder what her parents' view of marijuana would be, if they would say, if their viewpoint would have been, maybe you need to lead a sober life completely. And so, honoring them might be a positive thing for her.
That's a really good spin. Yeah, both of her parents would not have wanted her to use marijuana.
I think that it also might benefit to, you've already got a rapport with her, but I think it also might benefit her to, at least have a place to go where it's safe and she can talk about this, like whether or not she realizes that she doesn't want to do therapy. You don't have to label it therapy, because half the time people are like, oh, you're going to get in my head. So even if you just say, hey, I'm going to meet you individually and we're just going to chat about this stuff and do therapy without labeling it therapy, eventually next thing you know, you guys are talking about stuff and she's starting to process stuff. It's a slow but step-by-step process. I have a lot of information that might be able to help you in my slides and what I talk about today, but I do think if it's not impacting the group, and she keeps showing up for groups, so maybe she's getting something out of that cohesion, because that connection within group is so important. And that's definitely something that I've recognized within my little marijuana coat group. But that also might be helpful when it comes to like just hearing from other members of the group saying like, hey, listen, like I'm not using marijuana anymore and I feel X, Y, and Z, or I've noticed this, this, and this, and I can go on walks with my kids. I can, exercise, and that might help, raise or do all the benefits that exercise does, but it might be able to kind of get the way in, and then on top of it, increase her motivation and seeing financial, relief from it and things like that. But there's so many different aspects of it. And like, I'm definitely like being there and showing up and showing that you're not giving up goes a long way. So keep going.
Oh yeah, and if other people in the group are able to see that you can have a non-judgmental discussion about using other substances, they might be like more apt to say, hey, I did something too. So then they're being a little bit more honest about it. And now Sarah's
Yes.
touching her nose, and I don't know
I
what
see that,
means.
Dr. Husted, one moment, could David has his hand raised. Is that okay?
That's so Adina, I've got a patient who, and we have a lot of marijuana patients who just quit marijuana after 5 years of being off her heroin. She was in group every week for 5 years. Maybe Christmas wasn't one of them. Yeah, we just didn't move her up, and she didn't mind coming in. And then she's actually been a big force for other people because she can say, well, I actually do feel better now that I'm 3 months out of this. Took a long time to get out of her system, and wants to go back to college, get her master's degree. She already has a bachelor's. She says, I don't feel tired. My motivation's better. All the things that we try to convince people that will happen, but we don't often see. But she, so I wouldn't, if she likes group, I've got people that are 5-6 years just because we're figuring out what to do with all that, people. But there does come a point where, are they getting anything out of that group? That's what we're struggling with. So, but if they think they're getting something out of it, it takes up a space that somebody else could use. But she finally quit marijuana and hasn't touched it in, I think, 5 months now after 5 years. And again, it's not that I have this huge, but she had an addiction. She couldn't function as well as she wanted with her kids and her life, and it was holding her down. So it's a step she needed to take. So.
Dr. Husted, go ahead.
Yeah, I was just gonna say, if you keep her in group, I think that's fine. Just I wouldn't turn it into this like battle or like a marketing thing for her where she's singing its praises all day, because you could have the reverse effect where suddenly people like get emboldened by her. They're like, oh, you had depression, anxiety, and now you're better. Do that. If she's gonna stay in group, I would just be very careful with how you approach it. So I'll often say, if I know someone's struggling with marijuana, I'm more like, okay, how long have you been without opioids? Great, 2 years. How's the marijuana going? Okay, not yet. All right, great. Well, but not. I don't know. It's a knife edge to walk. I think you go both ways. If it goes well, you can encourage other people to stop, and if it doesn't, then next thing you know, you might have 6 people struggling with marijuana. So we'll see.
Adina, what does success look like to her? If you were to ask her that, what does a successful life for her look like?
She feels that she has it now. So her successful life, she wanted to get off of opioids, stop having to go back and forth to the hospital. She's no longer afraid of overdose. All of her medical problems, except a little bit of back pain, have resolved. Her mood is stabilized. She has repaired the relationship with her sister. Her family counts on her. Her daughter actually moved in with her and brought a boyfriend because she's actually very stable, very, very sensible, very down to earth woman. So she never thought she would be as good as she is now. So for her, she's reached her pinnacle. Now, what does bother her is that she knows, well, she has this issue with marijuana, but it doesn't bother her to the point where she wants to stop.
So correct me if I'm wrong, but I've heard the problem was that she just won't come to a group more often than once a month, even though that is what she's supposed to be doing. Is that right?
Yeah, because if you still use a substance, in our program, we try to offer you a higher level of care.
Right.
The problem is, I can't make her come weekly, right? I can't make her come bi-weekly.
What would you do with another patient who was just not showing up for their visits?
Well, I would meet with them and talk to them and see what's going on with their visits and decide whether they need a high level of care in terms of rehab or whether they wanted to continue with the program. The thing is, she wants to continue the program. The other patients, though, are in Suboxone. So if I'm trying to get them to come to IOP, I give a limited amount of medications. Vivitrol is a monthly injection. There's no way I can give her a limited amount of medications. So it's kind of stuck. And we never actually escalated her to a month. She just stopped coming because it wasn't as beneficial for her anymore because everything else stabilized. But she does see benefit in coming and touching base, once a month.
Could you increase her like screening accountability or something, or have some, like if you're not going to come to group like you're supposed to on a weekly basis, you need to come screen more often, or have something of that nature?
No, because I know she's going to be positive for marijuana. So I didn't see the benefit in increasing that, because after a while, Medicaid, they give you problems, right? They're not going to pay for that. And if she does, or if she doesn't, what will be the consequence?
Yeah, Dina, this was such a great case to present, and great timing right before Sarah's presentation. And you said earlier you felt like this was a double standard. And in fact, I think it isn't. Her treatment does look a little different because her medication treatment looks different. And I think that's opening you up to opportunities to treat her case a little different in the ways that a lot of these folks have suggested. So I really appreciate that kind of open thinking you're having about how can I meet her where she's at, because potentially pushing her in a different direction wouldn't go well.
I wanted to add too, like, looking at how other clients see it, like what are other clients going to think? I've dealt with that before with clients seeing a team decision as differential treatment because the team reacted to them differently in a similar situation. And what I come back with, and I'll write it on the board in big capital letter, YOUR. Your recovery is your recovery. And they don't need to be worrying about anybody else's recovery. I tell them that, whenever anybody has an extenuating circumstance, we're going to meet with them as a team and we're going to meet them where they're at. And they just have to have faith in us as a team and as a program that we're making the best decisions for each patient individually. But, we're also still a team, we're also still a group, but when it comes to everybody's personal lives, they don't need to know everybody's details.
And one of the things that you might be able to kind of work on to get her to come in for more screens is that if she doesn't have a medical card, there is an increasing number of marijuana that's not bought in dispensaries being laced with different things. I also work on the trauma service and I see it all the time where people are like, oh, I only smoke marijuana. Well, then why is there fentanyl? Why is there methamphetamines in your system? They're like, I have no idea where this came from. And so with the dispensaries becoming kind of the standard level, other places have to, like Black Market has to compete with the marijuana. And if they can continue to make it more addictive or more psychotropic or anything like that, they're going to, because they can't keep up with the levels of THC that is available at the dispensaries versus not. So that might be another reason to have her come in and screen more, just to make sure you're monitoring her THC levels, and if they're consistent, that says something. But also making sure that she's getting stuff that isn't tainted, because obviously you already know that the stuff at the dispensary is a little bit safer than stuff that she's going to go buy from random person on the side of the street. Or even if they know their dealer, half the time the dealer doesn't know where it comes from, like, because you can't trust that, because we had to have a song for people. Yeah, we had to have a song for people to wash their hands. Like, I can't guarantee that the person packaging it washed their hands. Like, so we have to really kind of take that into consideration when it comes to what's in it, what's potentially being on it. Like, we had another client who was positive. I think she was positive for E. coli even during one of her screen when she was kind of really struggling with different stuff. And it's a really, really scary thing, but I'm seeing it more and more and more for people who are just like, oh, I tried it for the first time, and it's laced with different things. So just that might be another way to get her in.
Thanks. And thanks, Nikki.
Public service announcement for those that don't know, the state Congress passed the bill banning Delta 8 and Delta 10, all the other Deltas. And that just needs to be signed by the governor, and then you won't be able to see it at gas stations anymore.
So glad.
Yes, it's about time. One other thing is when people buy CBD oil, just so everybody knows, the CBD, like hemp, tends to grab a hold of heavy metals in the soil. So one concern you can have is someone might be on CBD and be fine from that, but could be getting like lead poisoning or some other things in the process. So you get like weird neurologic effects, you might want to go down that route and look into heavy metals. But that is a concern when people with hemp and some of these products, just there's no controls over that stuff. So there you go.
Wow, thank you guys so much. Heavy metals and stuff, that's really scary. Didn't know that, so that's cool. But thank you guys so much for your input, and thank you so much for the case. Please, if you don't mind, maybe doing a follow-up on this case later on. If any changes, I think that'd be really interesting for the group to see. We love a good follow-up case. And Sarah, are you ready?
Yes.
All right, perfect. Did you want me to do, or do you want to control them yourself?
You can do it. And I can just say
All
next
right.
slide so I don't
Yeah,
get
that's completely fine. All right, give me one moment.
I know my limitations.
Can you see that?
Mm-hmm.
Awesome. Take it away.
Okay, so I'm Sarah. I'm a clinical therapist with WVU medicine. I work with the co-program. I also work with trauma, as I said previously. So again, part of what makes us a level 1 trauma center is having therapists go in to do a brief screening. And so I also have that kind of fortunate perspective when it comes to marijuana use, especially when, we have an older generation. Tony just sent me an article today that highlights like the increased confusion and falls and everything that the older generation is kind of having through marijuana use. So a lot of times I do see, oh, I just had some marijuana and I fell down. And, it's older people that are kind of using it for the first time. So this is, part of what I kind of see in the program or just in my practice in general. So part of the things that we kind of discovered that we needed was a marijuana program, like a marijuana kind of based coat group that really does allows us to work with people a little bit easier. So so that little QR code, I don't have any animals that have buffalo plaid outfits. So I decided to do a thing where I'm putting animals that are up for adoption for Animal Friends of North Central West Virginia. So if you put your little camera on the little QR code, and it's going to be on later, but so there's going to be pictures of animals in my slides that are up for adoption if you guys are interested. Just
thanks,
putting it
Sarah.
out there.
Thanks. No, that's amazing, but I might get in trouble.
Yeah, like I just don't have any buffalo plaid things, and I have a buffalo plaid jacket, but I don't think my dogs would appreciate it. So next slide, please. All right, so I have no conflicts of interest other than like I don't endorse marijuana use with Suboxone or any sort of we recognize that smoking it, taking it, like there just isn't enough research out there to really say, okay, these are the benefits, these are the different implications, all of these things. So that's pretty much it. Obviously, this is Cricket. She is up for adoption, and she's very, very cute. Next slide, please. This is Udon, who is a kitty that's also up for adoption. So some of the goals, I just want to identify 3 treatment considerations for opiate use disorder, therapeutic treatment, and continued marijuana use while somebody is struggling with opiate use disorder or recovering from opiate use disorder. Because there's a lot of different layers to this. So one of the things that I'm going to really focus on is client-centered treatment. We kind of touched on that a little bit earlier with the case presentation, but I'll elaborate a little bit more. And then also consider how connection amongst peers within our programming can help facilitate sobriety. When you guys have a question, please just ask. I will try to keep up on the chat box, but I definitely, if there's a question, I'm all about it, just ask. Next slide, please. This is Maisie, and she is also up for adoption. So the common arguments that we hear a lot of times, like, oh, everybody's using it, it's just a plant, like at least it's not fentanyl, at least it's not heroin, it's legal in many states, like medical marijuana use is okay, like all these things. There is a huge element of socially acceptable kind of uses for marijuana, and so like we can't discredit how society views things. So, and the fact that people think, oh, this helps treat my anxiety, without having to do the hard stuff like therapy. Next slide. Ivan, obviously up for adoption, and it's a ginger cat, so they can be a little bit of chaos, as most gingers are. So we started this THC coat in October of 2021, like September, October. This started to be in the works because we noticed that there was a lot of people, and there's a lot of people that helped start this thing. And it just so happens that I got to be the original therapist for this group when it was at its beginning. So there was a lot of people that we noticed they kept relapsing on marijuana and in their UDSs and stuff like that. So they go through the cycle of levels of care. Back then we had a thing where, if you went through all the cycles, you would go 30 days outside of the program in order, and then have to come back in once you failed so many times. But one of the requirements for this is they have to have a desire to change, no relapse on harder substances, and they're fairly stable outside of the marijuana use. Next slide. So some of the considerations that are kind of important. So one of the things that really kind of had me thinking during the case presentation today is because of the opioid epidemic, there is a lot of skepticism surrounding what doctors say, what studies say, what is kind of prescribed versus not prescribed. And so like, because of the opioid epidemic, especially when we look at prescribed medications, I feel like society and a lot of times our clients are a little bit skeptical. Like, okay, why do you want me to do this? Why do you want me to do that? Especially after, how things went down and how we basically lost way too many people to overdose and through opiate use and everything else like that. And so like, it's hard pressed to live in West Virginia and not know somebody that hasn't been lost to that fight. So a lot of our clients that I've noticed can be kind of skeptical of doctors and what they prescribe and things like that. So I think that's a part of the element there too. Like, okay, well, you want me to stop this, but why? And so like that kind of fear of, well, this isn't prescribed and this is natural. So why do you want me to start, stop using this and start following what you say? And so I think that's a big little bit of part of it. So I know Dr. Hirschler said, what does success look like? And that's another part of it when you work on client-focused treatment. So what does success look like? And sometimes we do have to redefine what that looks like for each client. And luckily, because we have such a small kind of group, and this is a specialty group, we do have that opportunity. And Tony DiCiacchio, she is our prescriber for that group, who is also in this chat somewhere. And I just see the pictures on the side here. So she's in here somewhere. So having that kind of discussion amongst the team too, like what does success look like for this person or that person? And so like kind of having that opportunity to meet people where they are, that's a big part of it, especially as change goes slowly and everybody is at different stages of change, different parts of their hierarchy needs. So I think the treatment like team aspect is a big part of, what we view as success. And so they might not, stop using marijuana. However, their levels are consistent, or they are reducing slowly, or they're starting to think like, hey, maybe this isn't working. But because of our group and team effort, we have provided a space for them to feel comfortable enough to talk about it. So one of the things, luckily, Dr. Husted shared the good news of the regulations with Delta 8, 9, 10, like all of them, the CBD, like luckily, like that's starting to change. And this is the first time I've heard of it. So hopefully it does make a change and I won't have to see it in the gas station or Gabe's or, you know, any place that they could have a register and sell them, because that's pretty much where it is. Some of the modalities that I use, especially for therapeutic treatment, I definitely use a good bit of DBT and motivational interviewing, of course, but a lot of times it's just meeting people where they are. That's a big part of it. So the language that we use is also a big consideration. Instead of saying, okay, you're a person, you're an addict, you're a person who is struggling with addiction, or, you know, you're just a pothead. No, you're a person struggling with THC use. I'm like dropping my computer, so that's cool. My bad. So it's a person that's struggling with THC use and different stuff like that. That's just what happens when I talk with my hands a lot. I flail a good bit. And anybody who knows me definitely recognizes that I flail a little bit. And Derek's laughing his face off, so he knows. Language is important. And a lot of times that changes how we view ourselves. And that's a big, big part of it. Because if we can view ourselves in a way that has a positive light, a lot of times that does make a huge difference. So also, when people prescribe medical marijuana, when there's maybe a 5-minute discussion with the person, hey, what are you diagnosed with? What do you have? Like, what's going on? And so it's that 5-10 minute conversation, and then they write a script after paying $150. And then, you know, going through the process to get the medical marijuana card through West Virginia. And a lot of people, you know, as money can be an issue, a lot of people don't see the point, or they don't know the laws. Like they think, oh, well, you know, this is medical use. All I have to do is say this is for medical use and it'd be fine. So there is kind of a big misnomer of what is medical marijuana and what is just regular marijuana use. Next slide. There we go. So, you know, for our structure for the TH code, it's a weekly program. They cannot move up until they meet sobriety from marijuana for 90 days. And we've had a couple clients do it. I'm not gonna lie, it's rare. Graduation's rare. This can be a very frustrating situation, because it's just like, damn it, just stop using marijuana. But it's rarely that easy, especially when it comes to addiction, despite it being not habit forming. So recognizing that, hey, you know, this might be a problem, might take a little bit. Some of it is financial, a lot of it is health issues. There's normally a thing that happens in order to kind of spur that movement on of sobriety from marijuana, but it does take a good bit of time. So it's a weekly thing. There's graduation after 90 days of being sober, and it is very client focused. We meet for different needs for each client. We do have a very, very open communication, and we do reach out to different providers, be it their individual therapists, their psychiatrists, like just say, hey, heads up, you know, in group, this is happening, or this is what I've noticed in group. And so we do have that open communication with the other providers as well as with the clients. And that's really been a godsend when it comes to establishing safety and allowing these clients just to have this non-judgmental space where they can just talk about their issues and realize that they're worth something. I have a client who in this co-group that is planning a trip to Disneyland, and one of my clients in that, and another peer said, who knew that a bunch of addicts, he didn't say addicts, he said the J word, said, who knew a bunch of us could actually go on vacation and do these normal things and live these lives. So a lot of times, like, having that opportunity to give that space and having that recognition and pointing out to them, like, you're worth more than what you thought you were worth. And so that makes a big difference just for the realization between the peers. So we also go into it, like, therapeutically, sobriety impacts all things and all things impact sobriety. We recognize that it's not an or, it's an and. It's both things can influence it. So there's really nothing that's not off the table when it comes to different topics that we discuss in therapy. And a lot of times it is focusing on what's kind of going on in their lives. If I pick up on a theme throughout med management, or, you know, if people are starting to struggle with different, you know, family things, communication things, like, normally we can have a very good discussion on it. So we always assume I knew I was going to mess it up. Phenomenological empathy. So it's a DBT kind of perspective, where we assume that the clients that are in the group want change, they want sobriety, or else they wouldn't be there. They want to make these positive aspects of their lives and different, because the way that they've lived isn't always great. And so we got to figure out what the pieces are to get that change, to get it going. And if it is something like, oh, I can't afford this anymore, or I can't, you know, I'm having these health issues. And like I said, Tony sent me an article that was published today in the Wall Street Journal, and they're finding more and more older people having issues with drug interaction and the way that THC is metabolized in their system. So there's a lot of different things that we're starting to find out finally, that marijuana is kind of impacting. So a lot of times this comes from just talking about it and having education and trauma-informed care, because it's hard pressed to find somebody struggling with addiction that hasn't had some sort of trauma in their life somewhere, be it chicken or the egg, if it came before or after they started active addiction. It's a matter of kind of when, not if. Next slide, please. All right, so we got Swiss Roll here, who is just chilling in a toy box, which I respect. So we got some changes. So some of the things that we were able to change that makes our TH code different than regular code is that this group is one of the most consistent groups for attendance that I have versus any of my other weekly groups. I only have one other weekly group, but they are pretty consistent with showing up for each other. They're very vulnerable. They have the space. They've created the space for themselves. And I always say, like, I'm not the leader. I'm just a tool. I'm here to allow you to be supported and facilitate conversations and making sure that you feel okay. And so they feel like they can be honest. And so having that autonomy and accepting that they are the authority of their situation and they deserve to be on their team has been a big part of it. There's been even times where we've been able to post to the group, hey, this is going on. What do you guys think? What's the perspective? How can we kind of keep you in the loop here? Because sometimes they have some great freaking ideas. Sometimes they're a little sadistic, and I'm like, whoa, guys, like, we don't have to make them walk through fire for this. But, you know, it also shows that kind of equal accountability with the peers and the client that has the issue. So that kind of acceptance for themselves and peers, and that kind of, you know, cross accountability can be a big helper. And that kind of a connection, like, just allows the space for people to be like, I don't know if I want to do this again. And so, like, having space for that has been a really big part of it. All right. And, you know, it takes time for this to establish. Like I said, this group started in October of 2021. So we've got 2 or 3 original clients, and then we've collected more over the years. But it's definitely taken some time to get to where we are now. Next slide. So again, some of my observations, just being a therapist and facilitating this group. I've worked inpatient and outpatient, so I've definitely got a range of perspectives. The THC levels have been, fairly consistent and pretty low. There has been a gradual decrease in most of their THC use. Roughly the average was about 200. Their levels roughly sit about 200, 250. And so like having that kind of low and consistent levels of THC have definitely been something that kind of surprised me. And, whether they admit it or not, there's changes happening. Whatever it may be, whatever's facilitating it, I don't care. There's changes happening, which is great. A lot of these clients do have 5 years sobriety, 10 years sobriety off of opioids. So they've been around a little bit and they've been able to figure out what helps them stay stable and what helps them, not relapse on this stuff. And the recent uptick of fentanyl being in marijuana has definitely sent a couple of, shocked a few of them. Because they they swear up and down they've only used marijuana, but there is definitely fentanyl or, X, Y, and Z in their system. And so that's definitely been a shock to them. So they really respect our team. They really respect the lengths that we're willing to go to work with them. That's one of their things that they consistently report on. They recognize they can reach out to us and we respond. We're very involved in their care, and they recognize that we do care instead of just another okay, here's your script, let's go, just a thing. Tony really does take the time to check on their medications, and we get to know them, and they tend to have more open communications, and they freely send messages to each member of the team. So overall, their marijuana use has definitely served a purpose, whether it's fear, whether they're just not ready to totally give up that addiction lifestyle, whatever it may be, it serves a purpose. We just have to figure it out. Whether they know it serves a purpose or not, it does serve a purpose. A lot of times, a lot of these clients do start off with marijuana. And so this has been their longest relationship of their life. Because they might not have family anymore. They might not have friends. This has been the longest consistent relationship of their life. And that's also important for this team as well. This is because they've cycled through so many times. This is the longest they've been treated by a single therapist and a doctor in a very, very long time. Because that consistency, I think, plays a huge role in that. So we also have to recognize the generational addiction trauma kind of thing that really has maybe played a big part in their addiction, but also as they grow, as they look for new lifestyle changes. We have a few that recognize hey, I'm tired of this job, I want a new job, and they're able to kind of go out and ask for that, which is something that they've never done necessarily before, or go out and say, hey, I want to apply for this job, or I talked to so-and-so about this job. And so that's been a huge kind of indicator that I haven't seen in any of my other groups. Just that kind of support where they can go and they can show up on Friday evenings and say, hey, this is what's in my life right now, and this is what's going on. Can I talk to you about it? And it's not just job stuff, but it's family stuff. Hey, my mom's XYZ. So it's a really great place to allow them to speak their mind and feel that they're worthy of speaking their mind, and they're worthy of the support that they're getting through this co-group. Next slide. There we go. We got Sammy here. So again, with the client feedback, one of the main things that main themes that they've said is that because there is a non-judgmental stance in the group, we give them the education, we give them, hey, this is bad and this is why it's bad. And so making sure that they, get that little bit of education, and of course, you know, there's going to be some resistance. There's going to be some hesitation towards change. But they say, like, because we have that non-judgmental stance, there's less shame. And so they can be honest about it. They don't say, oh, I've been sober, you know, 2 weeks. They feel like they can be more honest about it. And I don't think that each person's like, I don't think it perpetuates. I think that each group is each client is very invested in other people's, you know, life and recovery. And so like, I don't necessarily think it's egging them on. I think it's a more accepting place where they can say, hey, yeah, I relapsed because of this, this, and this. And so the immediate, you know, detriment of marijuana isn't always recognized right at initially, just like, you know, when people start to get sober, one of the last things to go is cigarettes. And so it's very similar of, I want to just hang on to this. It serves some purpose. There's all sorts of education out there that say cigarettes are bad. There's all sorts of education out there that say alcohol is bad, like all these different things. And I'm not comparing, you know, they're saying they're equal by any means, but there's definitely something to be said for why they keep using. And there's a connection there. So again, we have that flexibility where clients are able to communicate their needs, whereas and the team seems to understand that. And there is a very big sense of community within this group, which is something that they've struggled to kind of get back to, you know, since COVID and everything else like that. So they are surprisingly connective for being an online group. I do believe that honesty and safety sets the stage for change. And since, you know, we do have this group where, you know, we're trying to be non-judgmental towards marijuana use, like we're pretty open with saying, hey, you know, not a fan of this, but we're not saying, oh, you're a bad person because you relapsed. I do think that this, because they don't have to cycle through, I think there's definitely less overdoses out there on fentanyl and things like that, because we're kind of meeting them where they are. Next slide. So compromises and limitations. So as I mentioned earlier, I'm not afraid to ask the group about potential solutions and everything else like that. They can't move forward in the co-program until they get the 90 days sober. So they are stuck weekly until they start to really work on, you know, sobriety from THC. We were requiring individual therapy at the start of it. So a lot of times they didn't show up, or they couldn't get it fit in their work schedule. There weren't enough therapists or open slots or anything like that. And so like we kind of did away with that because it started to cause more problems than not. Because we would have to say, oh, this is your early out because you missed therapy. And so some of them did end up staying with individual therapists, which is great. Some of them gained individual therapists and have been consistent with individual therapy, which is another great thing. And so like even setting the stage for that change and knowing that they have the group in individual therapy, I think has been a huge factor in it. When, hey, I've started to process this trauma or X, Y, and Z. Most of the people going to higher level of care is because they miss their UDSs. They're allowed to miss 2 UDSs every 6 weeks. And so most of them that have gone on to higher levels of care is because of that. It's also hard because external forces really do help drive change. One of my clients is very invested in his Aura ring. And so like he is very much like, okay, this is my I notice my sleep's bad. I notice this is going bad, and through his Aura ring. And it's kind of, we get to plant the seeds of like, I wonder if marijuana has any play on that. And so just like allowing those little kind of organic situations where we can kind of call that out a little bit, it really, really helps. So next slide. All right, so questions, comments, concerns, recipes, anything. I know I really ran through that pretty quick because we only had a little bit of time, but if there's any questions, I'm more than happy. I understand that, people might have questions or need to pop off, but I'm here, so I'm down for everything. And also this is, again, the QR code for all the animals.
Awesome job, Sarah. Thank you so much. You're just a natural and love the animals. So those will be in the slides, everyone, if you are like me and need more dogs always. So any questions or comments? We did have some good comments in the chat. Saying thank you, and Katie really enjoyed it. Trying to scroll down, sorry. Wonderful. Thank you for reminders of working with this group from a very non-judgmental stance, and for the reminder of our definition of success may be different than their definition, and we need to honor that. So
it's
well
hard.
said.
It's really hard because it's just like, we want you to be successful when we want it so bad, but if it only took us wanting it for them, then we wouldn't have addiction. But that's just kind of where it is.
I want to share a technique that I've used over the years that seems pretty helpful. What I'll often say to patients that are chronic marijuana users is, let's do an experiment and see, you know, if you were sober for 30 days from marijuana, what would life be like? Because they have no idea. They've been using it for years and years and really don't know what the difference would be. And so I'll say, you take a vacation from marijuana for 30 days and let's just see where you're at.
Even hell, I've even done 14 days. Like, I've done just a little bit of time. And a lot of things that really kind of help them too is I add it up. Like, I'll pull out the old calculator and be like, do. And then I also add in how much actual time does that take from you? And then let's say you earn $20 an hour and it's done taking away 5 hours. You know, that's $100 on top of what you've already paid.
Thank you very much. Well said. Any other comments or questions? We do have a poll if you have time. I know it's we're right at that
Sarah,
time, but go ahead. I'll pop it up as you talk.
Yeah, Sarah, quick question. So how long before they go into the THC group do they have to be off opiate or opioids? Is it a year or?
It depends on how much, like, we obviously want them to give a really good try with the regular coat clinic. And so it just kind of depends on where each client is at, but most of them, their struggle has been opiates. I think has been just getting off of marijuana. And I think the one that has the shortest amount of time from opiates, it's gotta be, I think, a year. But it's not by design. It's just the way that the cookies kind of fell. But as long as they have the desire to change and they've cycled through, you know, our I code, our A code, all of that, then they're more than willing, and they have that drive to change. They're more than willing to join us in the group.
And how long do you do the group? Forever if they stay on marijuana forever? I mean, we did it for 8 weeks and found it was hard to carry it beyond that, you know, so we required them and switched them over. But yeah, I was curious if you just keep doing it or I don't know.
I'm a little bit like the Energizer Bunny, so I just keep going and going and going until they don't go anymore. So far it's been going on since 2021, and and that's okay. Like, life throws you weird curveballs all the time, and I can freaking talk. So I do those therapeutic interventions as long and as off as I can. So I think having the background of being an inpatient therapist has definitely helped me meet people where they are, because, you know, you do get burnout inpatient where you see the same people coming in. And I think that, you know, I'll be there as long as they are.
Sarah, thanks for the presentation. Just one question. Is there any medications that you guys use for short periods of time? Or Yes, Tony. She uses NAC, N-acetylcysteine. Did I say that right?
Yep.
Yeah.
And
that really helps with cravings.
Some Topamax.
And Topamax, yeah.
How successful is that?
The N-acetylcysteine has been effective for a couple patients. I wouldn't say it has been overwhelmingly successful. The Topamax, as you would expect with Topamax, if people can tolerate the side effects, I've had a couple people need to come off from side effects, but if they can tolerate the side effects and we get to above like 50 milligrams, like 100 milligrams twice a day, for a few people that's been effective. But I can't say that there's any medication as effective as like buprenorphine is for opioid use disorder, unfortunately.
Yeah.
Thank you.
But also like making sure that they have the space to even consider, hey, maybe marijuana is not as helpful as what I thought it was.
And Sarah was right on the money with their kind of ambivalence or maybe mistrust of Western medicine and pharmacology, and they frequently say, well, this is a natural plant, and why should I take that? There's so many side effects when this is safe and healthy. But we continue, and I even took the course to be a cannabis certifier, even though I can't because I'm a nurse practitioner, not a physician. But even in that, I learned a lot that they teach as cannabis certified physicians of the side effects, and I bring that to this group, and I'm just as vulnerable with them as they are with me, saying, I'm not sure I'm doing the right thing by you. I sometimes feel like I'm enabling you, but I just want the best for you. And we constantly talk about this group as kind of experimental, and we're kind of flying by the seat of our pants and doing what we think is harm reduction, and let us know if there's something better we can do.
Yeah, there is much of part of the team as Tony, Kate, our case manager, and I are, and just recognizing like, hey, we have to try something different because this is not working and it's doing a lot of harm, whether you believe it or not. It's doing a lot more harm than what we potentially realize. It's just, that instant gratification versus delayed has really been something that can lead us to banging our head against the wall a little bit. Yeah, pregnancy is a very fine line to walk. I have a few pregnant clients and I'm like, I don't know about this, but she claims that most of the people that she meets on her OB team has been accepting of marijuana. So
I actually worry less about heroin than marijuana, fetal brain development, which is kind of, and again, the data is still real scattered, but some of the teenage data, now the elderly data, fetal data, it could be worse. I don't know, but I can't say it's any safer because it's natural on that side.
It's definitely worse on a fetal brain. No, I mean it is. I mean,
Thanks.
really,
no, that's what I don't have a lot. Thanks, Jeremy.
Alcohol, cocaine, so stimulants, alcohol, and marijuana are by far the worst on fetal brain. Like opioids, you might have a sick baby, but you're not going to destroy their brain development. No, it's absolutely correct.
Wow, thank you guys. Thank you so much. This has been a very great discussion and really appreciate your time. But we are at that time, so thank you for those that did participate in the poll, and more importantly than the bigger poll that comes out. It's really a big deal, so we really appreciate that. Our next time we meet will be April 10th, and Katie will be discussing therapeutic treatments. So hope you have a great week, and thank you.